Pleasant good night, Miss Adams. Tonight I'll be presenting on sickle cell anemia, and the reason why I chose that particular disease is because it's very prominent among African people and people with African ancestry. I will first go into the causes, clinical diagnosis, the pathophysiology of the disease, and of course treatment. Sickle cell anemia is caused by a mutation in the gene that tells your body to make the iron-rich compound that makes blood red and enables red blood cells to carry oxygen from your lungs throughout your body. In sickle cell anemia, the abnormal hemoglobin causes red blood cells to become rigid, sticky, and misshapen. Both mother and father must pass the defective form of the gene for a child to be affected. If only one parent passes the sickle cell gene to the child, that child will have the sickle cell trait, with one normal hemoglobin gene and one defective form of the gene. People with the sickle cell trait make both normal cell hemoglobin. Their blood might contain some sickle cells, but they generally don't have symptoms. They are carriers of disease, however, which means they can pass the gene to their children. The clinical diagnosis of the sickle cell anemia disease. Screening for sickle cell anemia is done with a simple blood test that detects the presence of the abnormal hemoglobin protein. In many countries, including the United States and Great Britain, this blood test is part of a newborn screening. However, unfortunately, it's not done in Trinidad until symptoms develop and parents suspect that their child may have been affected by that particular disease. Adults can also receive the test if they are concerned they might have sickle cell traits. Sickle cell anemia is most common among people of African descent, as I mentioned before, but can also be found in those of Hispanic, Southern European, Middle Eastern, or Asian descent. Patients who test positive for normal hemoglobin do not necessarily have sickle cell anemia and may only have a sickle cell trait. For this reason, further testing is needed to make a definite diagnosis. A blood test may also be repeated to rule out a false positive test. Several types of sickle cell anemia exist depending on which type of abnormal hemoglobin the patient's body makes. These vary in the severity of symptoms. A second, more specific blood test is used to determine which type of abnormal hemoglobin a patient has. A test for sickle cell anemia may also be performed before birth using a small sample of amniotic fluid or the placenta. These tests screen for the mutated HBB gene rather than the abnormal hemoglobin protein. Patients diagnosed with sickle cell anemia require frequent laboratory testing, including blood and urine tests, in order to monitor them for complications like kidney problems or infections. Patients may also receive a transcranial Doppler ultrasound screening, a painless procedure that uses sound waves to examine blood flow in the brain. It lets doctors assess the risk of stroke and start treatments to reduce that risk if necessary. Genetic counseling. Patients with sickle cell traits or parents of newborn babies diagnosed with sickle cell anemia or sickle cell traits are often referred to genetic counseling. This helps prospective parents determine the probability of future children inheriting the disease and helps them make fully informed reproductive decisions. Pathophysiology of sickle cell disease. Sickle cell disease is caused by a mutation in the beta globin chain of the hemoglobin molecule, right? So basically, HBS arises from a mutation substituting thymine for adenine in the 6th codon of the beta chain gene, GAG to GTG. This causes coding of valine instead of glutamate in position 6 of the HB beta chain. The resulting HB has the physical properties of forming polymers under deoxy conditions. It also exhibits changes in solubility and molecular stability. These properties are responsible for the profound clinical expressions of the sickling syndromes. Under deoxy conditions, HBS undergoes marked decrease in solubility, increased viscosity, and polymer formation at concentrations exceeding 30 grams per dia. It forms a gel-like substance containing hemoglobin crystals called tactoids. The gel-like form of HB is in equilibrium with its liquid-soluble form. A number of factors influence the equilibrium, including oxygen tension, concentration of HbS, which is the sickle cell hemoglobin, and the presence of other hemoglobins. Oxygen tension is a factor in the polymer formation, which occurs only in the deoxy state. If oxygen is present, the liquid state prevails. Concentration of sickle hemoglobin is a factor in that gelatin of sickle hemoglobin occurs at concentrations greater than 20.8 grams per deciliter. The normal cellular HB concentrations is 30 grams per deciliter. The presence of other hemoglobins is a factor in that normal adult hemoglobin have inhibitory effect on jelly shell. These and other HB interactions affect the severity of clinical syndromes. HBSS produces a more severe disease than sickle cell HBC. HBSC, HBSD, HBSO, and HB, with one normal and one sickle allele. When red blood cells containing homozygous HBS are exposed to deoxy conditions, the sickling process begins. A slow and gradual polymer formation ensues. Electron microscopy reveals a parallel array of filaments. Repeated and prolonged sickling involves the membrane. The RBC assumes the characteristic sickle shape. Basically, this is just a picture showing molecular and cellular changes of hemoglobin S. After recurrent episodes of sickling, membrane damage occurs and the cells are no longer capable of resuming the biconcave shape upon reoxygenation. Thus, they become irreversibly sickle cells. From 5 to 50% of red blood cells permanently remain in the sickled shape. When RBCs sickle, they gain sodium and lose potassium. Membrane permeability to calcium increases, possibly due to, in part, the impairment in the calcium pump that depends on adenosine triphosphate. Cellular calcium concentration rises to 4 times the reference level. The membrane becomes more rigid, possibly due to the changes in cytoskeletal protein interactions. However, these changes are not found consistently. In addition, whether calcium is responsible for membrane rigidity is not clear. Membrane vesicle formation occurs and the lipid bilayer is perturbed. The outer leaflet has increased amounts of phosphatidyl ethanolamine and contains phosphatidylserine. The latter may play a role as a contributor to thrombosis, acting as a catalyst for plasma clotting factors. Membrane rigidity can be reversed in vitro by replacing HBS with HbA, suggesting that HBS interacts with the cell membrane. Now I'm going to talk about the treatment of a disease. The major features and symptoms of sickle cell anemia include fatigue and anemia, pain crisis, bacterial infections, leg ulcers, lung and heart injury, sudden pooling of blood in the spleen and liver congestion, even eye damage, bone infarcts. How would we treat this dreaded disease? Management of sickle cell anemia is usually aimed at avoiding pain episodes, relieving symptoms, and preventing complications. Treatments might include medications and blood transfusions for some children and teenagers. A stem cell transplant might cure the disease. Some medications that we use for pain are crizanlizumab, The FDA recently approved this drug for treatment of sickle cell anemia. Given through a vein, it helps reduce the frequency of pain crisis. Side effects can include nausea, joint pain, back pain, and fever. L-glutamine oral powder. The FDA recently approved this drug also for treatment of sickle cell anemia. It basically helps in reducing the frequency of the pain crisis as well. Preventing infections. Children with sickle cell anemia might receive penicillin between the ages of about 2 months old until at least age 5. Doing so helps prevent infections such as pneumonia, which can be life-threatening to children with sickle cell anemia. Adults who have sickle cell anemia may need to take penicillin throughout their lives if they have had pneumonia or surgery to remove their spleen. Childhood vaccinations are important for preventing disease in all children. They are even more important for children with sickle cell anemia because the infections can be severe. So basically, just to reiterate on aforementioned procedures, basically what happens with the blood transfusion is that in a red blood cell transfusion, red blood cells are removed from a supply of donated blood, then given through a vein to a person with sickle cell anemia. This increases the number of normal red blood cells, which helps reduce symptoms and complications. Basically, the risks include an immune response to the donor blood, which can make it hard to find future donors, infection, and excess iron buildup in your body. The stem cell transplant, also known as bone marrow transplant. This procedure involves replacing bone marrow affected by sickle cell anemia with healthy bone marrow from a donor. The procedure usually uses a matched donor, such as a sibling who doesn't have sickle cell anemia. In closing, because I'm pressed for time, sickle cell anemia is a disease which requires immediate attention. If unattended, the results may be fatal. Many still, to this day, are unaware of the risks and effects of such a lethal disease. People all over the world need to be aware of the possible dangers sickle cell holds and ways to prevent it from getting worse. Sickle cell needs to be heavily researched further in order to someday be able to find a cure for it. Until then, treatment options and paying attention will do the trick. Thank you.